Hello, today we are going to be talking about composite resin strip crowns. We will review their clinical indications, pluses and minuses from a clinical standpoint, and material selection, as well as technique. I will preface that there are lots of different ways to do composite resin strip crowns, and this is just my opinion and what has worked for me clinically. This is a nice flow of care from an article by Cohen from Inside Dentistry that shows the initial caries presentation, incisal and circumferential reduction, and proximal reduction. Strip crown forms from both the facial and incisal view, placing the composite resin in final outcomes. American Academy of Pediatric Dentistry Restorative Guidelines, a full coronal restoration of a carious primary incisor may be indicated when caries is present on multiple surfaces, the incisal edge is involved, cervical decalcification is extensive, pulp therapy is indicated, caries may be minor but oral hygiene is poor, or the child's behavior makes moisture control very difficult, which may be a contraindication for a composite resin strip crown, and then a glass ionomer strip crown may be a better outcome. Current retrospective studies show that composite resin strip crowns have a higher retention rate of about 80% after 3 years. Resin strip crowns are aesthetic to a certain point with high parental satisfaction when they are maintained, but they are technique sensitive and require sufficient tooth structure to provide surface area for bonding. Hemorrhage and saliva control are a must and can interfere with bonding of the material, and hemorrhage can affect the color of the crown form.
When looking at NOAC's Pediatric Dentistry textbook, resin strip crowns initially have very good aesthetics and may discolor over time. As far as durability, retention is dependent on the amount of tooth structure present and the quality of acid etch. Can be dislodged fairly easily if it is traumatized or there is contamination around bonding. The time for placement. Time is required for optimum isolation, etching, placement, and then finishing the tooth. Selection criteria. When aesthetics is a great concern and there's adequate tooth structure remaining for etching and bonding, and the child is not highly prone to trauma, and general hemorrhage can be controlled.
This article evaluating the long-term photographic and radiographic assessment of bonded resin composite strip crowns after 3 years found that bonded resin composite strip crowns were good restorative options for anterior primary incisors, with primary failures being loss of material, fracture of crown, discoloration, and staining to decrease parental satisfaction, but were still a stable restoration choice. Recent research in pediatric composite strip crowns is usually comparing preformed pediatric zirconia crowns longitudinally and comparing the two restorative materials. What they're finding is that there tend to be pretty equal treatments as far as outcomes, with pediatric zirconia crowns having better gingival health, dimensional stability, and color. This is from NOAC's Pediatric Dentistry looking at the step-by-step technique. The biggest concern is making sure you have adequate tooth space and structure to place your composite to allow for bonding. Generally, two variant shapes of pediatric strip crown forms. 3M makes a more anatomical collared strip crown that is slightly more technique sensitive due to the ability to be able to have to trim the collar off and to make sure that there is enough tooth structure removed to be able to place the crown form successfully over the tooth. These 3M crown formers will give a very highly aesthetic pediatric resin strip crown form. Space Maintainers Laboratories and NOAC Dental Supplies make a less anatomical pediatric crown form that is easier to place and trim and is a little less technique sensitive. NOAC Dental Supplies also makes a crown former with a vented lingual hole prefabricated, allowing composite to flow when placed. I think a great question you can ask next is, what composite should I be using, or what hemostatic agent? A lot of composites on the market now that are injectables, flowables, high viscosity bulk fill resins that are highly aesthetic nano-hybrid composites that'll give you aesthetic outcomes. Similarly with hemostatic agents, I would recommend something that is non-staining and that will give you an aesthetic outcome once rinsed. In these clinical examples, we're going to be using TPH low viscosity composite and Traxident hemostatic agent. appreciate sufficient circumferential reduction in space allowed for composite bonding.